Welcome everybody. The topic of my lecture will be the use of neural stem cell therapy in multiple sclerosis. Multiple sclerosis, as you know, it's a quite complex disease, and the problem is that disease is organ specific, so it's compartmentalized within the central nervous system, is multifocal. Unfortunately, there are multiple lesions within the brain and the spinal cord, and most importantly, the pathology of the disease is heterogeneous because we have inflammation, demyelination, and neurodegeneration which coexist. Therefore, the multiple sclerosis goal therapy should take into consideration several issues. The therapy should be specific. This means that should be capable of targeting multiple CNS areas, both in the brain and in the spinal cord. Should be targeted, so this means that it should be efficacious within the CNS, but not in the periphery, in particular in the progressive form of the disease, which is the course of MS I will be talking about. The therapy should be flexible, so capable of exerting multiple synergic therapeutic effects in order to challenge inflammation, demyelination, and axonal damage. And of course, if you want to move from bench to bedside, whatever therapy in MS should be clinical grade, easy to administer, and potentially you should be able to repeat the administration of this therapy. What about cell therapy and stem cell therapy in multiple sclerosis? We know now that there are different types of stem cells that might have a role in promoting remyelination and immunomodulation. Hematopoietic stem cells, mesenchymal stem cells, and neural stem cells. Remyelination can be also achieved by mobilizing endogenous stem cells or by transplanting stem cells. We know so far that regeneration of long tract axons and neurons by stem cell therapy is difficult to achieve. Nevertheless, what I would like to share with you is the use of neural stem cells in multiple sclerosis, and in particular, which could be the role of transplanting neural stem cells in multiple sclerosis patients. Nowadays, we have a huge amount of different stem cells because we have been developing several technological procedures in order to obtain stem cells from embryonic tissue, from fetal tissue, from cord blood, and also from adult cells. In particular, we know now that thanks to the work of Shinya Yamanaka, who got the Nobel Prize for this in 2012, we are also able to get stem cells from adult cells, in particular skin and blood cells. Therefore, we have a huge array of stem cells and the way of obtaining them in order to select the best cellular source for our purposes. I will be concentrated, as I anticipated, on neural cells, which can be obtained from embryonic tissue, fetal tissue, and also adult tissue. But in my talk, I will be concentrating on neural stem cells derived from fetal tissue. In beginning 2000, we decided to start working on neural stem cells in multiple sclerosis and in the experimental model, of course, on multiple sclerosis. And we decided, since we were dealing with a disease in which lesions are wherever around the brain and the spinal cord, to use a simple approach to inject neural stem cells intravenously or within the cerebrospinal fluid. In this way, we were convinced that our neural stem cells could reach the different areas in the brain and in the spinal cord. And actually, this is what occurred, because as you see in this movie, the neural stem cells injected intravenously or into the cerebrospinal fluid, the light blue ones, demonstrated to be able to reach inflamed area within the central nervous system, both in the brain and in the spinal cord, But surprisingly, what we found is that those cells, once within inflammatory plaques, did not differentiate themselves into mature neural cells, but they demonstrated to be able to secrete substances remaining undifferentiated neural stem cells, able to challenge autoimmune T cells, able to promote myelin regeneration, and also to block astrocytic scar formation. We also found that some of the cells we injected were able, very few of them, to differentiate into oligodendrocyte producing cells. Therefore, this was quite surprising because it was not expected, and therefore we continued in the years later to understand which was the reason why cells, neural stem cells, could promote neuroprotection by secreting substances. And more recently, we found that in particular in the experimental model of multiple sclerosis, this is due to the fact that neural stem cells, once injected, can secrete TGF-beta2, which is a cytokine that you know very well, which is able to inhibit the proliferation and maturation of monocyte dendritic cells, and therefore without the fully maturation of those cells, the autoimmune process could not be continued, and therefore this is the reason why the experimental disease ameliorated when we transplanted neural stem cells. So nowadays there is certainly a paradigm shift in the using of stem cells in brain diseases, because while until 2000 we were thinking that we could use those cells just to replace the cells which were damaged, from 2000 on, by demonstrating this sort of bystander paracrine effect, we were able to suggest that neural stem cells could be also used as stem cells to be injected into patients in order to modify, through the release of trophic factor and cytokine and chemokines, the pathogenic microenvironment. The situation nowadays is the following, that we've been summarized in this review. Whatever is the source of neural stem cells, once injected into the blood or the cerebrospinal fluid or in the parenchyma, these cells do possess a sort of pathotropism because they are able to reach inflamed CNS areas, and once within these areas they can do different things. That's the reason why we call this effect therapeutic plasticity, because they can certainly replace cells which have been damaged. They can promote trophic support by releasing of trophic factors. They can promote immunomodulation through the release of trophic factor and immunomodulatory molecules, and to some extent they can also induce some neural plasticity. But which is the way, in practical terms, which is the way upon transplantation these cells do operate within the central nervous system? What we know now is that when inflammation is ongoing, neural stem cells do remain as stem cells once transplanted, and in this way they can release cytokines, chemokines, and trophic factors, and in this way they can promote immunomodulation and trophic support. And this is a non-cell autonomous process. While this is, for example, what occurs when you inject neural stem cells in Parkinson's disease, when you have cellular degeneration and you inject neural stem cells, possibly already pre-committed to a certain neural phenotype in vitro before, they behave in a sort of cell autonomous fashion and they differentiate in the cells you would like to obtain. Therefore, the therapeutic effect of neural stem cells is very much depending on the microenvironment where the cells are injected, and depending on the interaction between the neural stem cells and the microenvironment, there is several therapeutic possibilities. Just an example, if you take neural stem cells, in this case derived from iPS, and if you inject them into an autoimmune inflammatory model of multiple sclerosis, such as experimental autoimmune encephalomyelitis, neural stem cells do not differentiate, and they start secreting trophic factors, in this case LIF, which is able to promote remyelination via fostering myelin producing capacity of endogenous cells. If you take the very same cells, but if you inject them into a toxic model of demyelination, like the lysolecithin model, this work has been done in collaboration with Anikman and Vercorin in Paris, what you find is that the cells do differentiate, in this case, into myelin-forming cell and start producing new myelin. So the very same cells, when inflammation is ongoing, they act in a sort of bystander fashion, while if you inject them in a non-inflammatory environment, they do differentiate and they produce myelin. We thought that those results were sufficiently solid to make us thinking about moving from bench to bedside, this kind of approach. Therefore, we start the journey from preclinical proof of concept work to clinical development, and this takes around 15 years, which is a long time, but the work that we have been doing was quite complicated. In 2003, we found that, again, injection of neural stem cells into EAE, both intrathecally or into the blood, were equally efficacious in reducing the disease burden. A few years later, we also showed that the ability of neural stem cells to reach demyelinating areas in experimental model was due to the fact that those cells were expressing cell adhesion molecule as well as chemokine receptors, and these receptors were able to make these cells getting into the brain more or less like lymphocytes do, and that was the way they could reach different inflammatory areas in the CNS. In 2009, we moved into monkeys, and we decided to transplant monkeys with EAE with human fetal derived neural stem cells, and we injected either in monkeys, intrathecally or into the blood cells into monkeys, and we at the same time used cyclosporine, because this was, of course, a sort of allogenic or xenogenic transplant. We found in monkey exactly the same therapeutic effect we have been demonstrated in mice a few years before. This was enough for us to think of moving into a sort of clinical development, and this is what we have been doing. And in particular, what we did first is to generate a platform to produce in a sort of GMP fashion, as requested by the regulatory authorities, neural stem cells. So we developed a very, very efficient production pipeline in which from a single fetus, human fetus, we can get billions of neural stem cells human grade. After a few years in which we've been developing this production system, we decided to move into a phase 1 clinical trial, which was a dose-escalating intrathecal human fetal neural stem cells injection, starting from 50 million, more or less, of cells in patients with progressive MS, ending up with 500 million cells, so 10 times more in the last patients. First of all, we generate the line to be developed into a drug product, and as you see, the way of developing such lines is quite complicated because there are a lot of different tissues that should be taken into consideration. However, we have been able to generate a line which fulfilled all the requirement to be used in humans, and once we got the cell line, we started, after having approved our trial by the national regulatory authorities, to enroll the patient with primary progressive MS, immunosuppressed, of course, with tacrolimus and prednisone only for a few days at the beginning of the transplantation, and of course the patient should be followed up for up to 2 years after transplantation. Interestingly enough, the cell line that we've been selected showed to express the famous receptor I've been talking about before, which are the receptors making these cells migratory into the brain. Therefore, as you see, these receptors, CXCR4, CD44, CD29, were the receptor which were the same that we found in mice and in monkeys. We then decided the characteristics of the progressive patient to be enrolled, and we enrolled patients with the progressive form of the disease, not responsive, of course, to approved therapies, and with a disease duration longer than 20 years and an EDSS of 6.5 or more. We were allowed to transplant 12 patients, and this is what we did. We started with the first patient in May 2017, and we ended up in May 2019 with the last patient. We could transplant 3 patients with the same dose of cells, around 50 million, so wait 3 months and then move to the second dose, 100 million, waiting 3 months, moving to the third dose of 250 million cells, and then to end up with the last 3 patients with 500 million cells per patient. So all the patients have been transplanted, and we are now following up them. Interestingly enough, this is a phase 1 trial. We didn't find any serious adverse event due to the cell transplantation in the 12 patients that we have been transplanting, and this is very reassuring. The side effect, as you see, the adverse events were minor. We recorded only a relapse in 1 patient, which was occurring 1.5 years after cell transplantation, so was not related to the cells, and therefore we are very happy so far of the safety of these therapies. 9 patients has already completed the 2 years follow-up without any problem, and the 3 last patients with the highest dose are still under scrutiny, and they are 1 year more to come in order to finish the follow-up. More interestingly is that we found in the patient that received the highest absolute number of cells, we found neural stem cells still circulating in his CSF 3 months after transplantation, because we took the CSF 3 months after to see what was going on there, and this means that the cells at least can survive up to 3 months in the CSF and continuing circulating. This is very, very important, because when we analyzed both at proteomic, metabolomic, and level, what happened within the CSF of the 12 patients 3 months after cell transplantation, we found that the microenvironment, the CSF microenvironment, was completely changed, and in particular we found that several chemokines, cytokines, and trophic factors were increased in different amount, indicating very clearly that these cells were able to modify the environment upon transplantation, and that the bystander effect that we described in mice and in monkey was also occurring in humans. And therefore, in my view, this is an indication that cells once transplanted are very active in releasing substances and promoting neuroprotection. We didn't find so far any adverse event, even in terms of disease progression. So we can conclude by saying that transplanted stem cells do not work therapeutically exclusively through cell replacement, but also via the bystander effect. Transplanted neural stem cells exert neuroprotective effect in 2 ways: by secreting trophic factor and immunomodulatory molecules able to restrain the inflammatory cascade, but also by fostering endogenous precursors to promote remyelination and to rescue damaged axons and neurons. Bench-to-bedside neural stem cell transplantation has started yet in MS, and in the 2 years of follow-up after intrathecal fetal MPC transplantation, we didn't find adverse side effect related to the transplanted cells. In transplanted patients, moreover, the bystander effect was measurable in the CSF as soon as 3 months post-transplantation. So, results so far are very reassuring. Of course, what is missing is that we should uncover in more detail the mechanism and mode of action of transplanted neural stem cells to find the best way to tightly control and regulate in vivo the various and potentially divergent therapeutic effects of stem cells. Therefore, this is something that we should take into consideration. Neural stem cells can be used in different ways. They can exert multiple therapeutic effects, but still we have to be sure how to control and regulate the different therapeutic effects these cells might exert. To conclude, I would like to thank all the people in the lab which have been contributing in the past 15 years to develop the technology and the concept behind what I've been showing to you. And of course, I would like also to thank the clinical scientists which have been working with us in order to make translational from bed to bedside a reality. It took a long time, but at the end we could make it, and this is something important in order to think about the new potential avenues in which to use neural stem cells in humans. Thank you very much.